Okay, we're going to go ahead and get started. We are on a schedule where we're going to kind of start finishing up this first part of this session at 10:55. We'll be able to have people that want to leave can leave, and then we'll answer questions, and then we're going to head into another session at 11. Okay, well, thank you everybody for coming to the last day of the UNC Water and Health Conference today. This is the Friday session. And the main difference between this day from the other days is that we are focusing on water quality issues in higher income countries, whereas the earlier parts of the week we're focusing on more low and middle income countries. So this track particularly is focused on protecting drinking water quality from both established and emerging contaminants in underserved communities. And we're all here today on a Friday because we're passionate about this topic, so we're going to have a fun Friday. My name is Jennifer Hopenick-Redman, and I lead our Environmental Health and Chemical Water Quality Program at RTI International. So what I'm going to do is kind of set the scene for what we mean when we're defining drinkable water, what kind of contaminants we're talking about and contaminant sources, and then also what we mean when we say underserved populations. Okay, so we just had a wonderful discussion with the administrator of EPA. And so first things first, we do have in higher income countries a variety of guidelines and standards for drinking water. Those do vary across country and agency. These are 3 examples from the US EPA, which regulates over 90 water contaminants. The World Health Organization internationally helps to provide guidelines so countries can inform those for their own standards. And then the Food and Drug Administration in the United States also helps set standards for food and beverages. So there are guidelines that we do have, but we know, and in hearing with the plenary from the EPA administrator, there's still more to go. There's more that we don't have regulated. So when we're looking at water sources in higher income countries, there's typically 3 ways that we get water. One is from municipal water sources. And in getting municipal water, the integrity of that water quality is really dependent on 4 areas. So it starts with source water, and water utilities often get their source water from a mix of both surface water sources and groundwater sources. And in that, sometimes that can introduce contaminants, including PFAS from industrial manufacturing, for example, or it could be naturally occurring arsenic, for example, in some groundwater resources. That source water then goes to the water treatment plant, where it's treated for, all water treatment plants are designed to reduce sediment and to disinfect the water from microbial concerns. Some systems do have tertiary treatment to remove additional compounds, and there's going to be more of that happening for PFAS in the future with regulations occurring, but that doesn't always happen. At this point in the process, disinfection byproducts can be introduced, though, to the water. And then the last 2 parts of the system are really getting the water to our tap. So there's distribution system integrity concerns, and then there's household concerns. And that's really what's in the piping and plumbing on the distribution side, where the municipal authority has control over. And that's where a lot is being done now on lead and copper. And then on the household side, what are the fixtures and the piping inside the system and the solder, and there's more being done on that to make sure there's lead-free fixtures. Another way we get water in higher income countries is via well water, and in those cases, the source water is groundwater next to the building or the household, and the people that use that water are solely responsible for the testing, treatment, and maintenance of that water. So the prior graphic, that person is responsible for all of that. So if you think of that, that person's like basically their own drinking water engineer, and that can lead to concerns because not everybody actually has a water engineering degree, right? And we provide little support, and there's no regulation in those circumstances. And lastly, and more increasingly, a lot of Americans and people worldwide in higher income countries are getting their water from bottled water because it's perceived as better, or in some cases, is it better? Better, maybe not. But companies use water from surface water, groundwater, and spring water to collect it for treatment. In some cases, there's reverse osmosis treatment, activated carbon. In other cases, it's noted to be bottled at the source. But we're increasingly finding that that bottling process and the use of plastics can create microplastics in the water. We're going to have a conversation on that too today. So the potential drinking water contaminants that we do find in our drinking water run the gamut from source water contaminants, including microbiological ones that Heather's going to be discussing, inorganic contaminants such as lead and arsenic, Michael's going to be discussing, organic contaminants such as PFAS, which Detlef will be discussing, and radiological contaminants such as uranium. The disinfection byproducts from treatment can also include things like chloroform, organics, or even aluminum from coagulation, and then distribution contaminants being lead and copper. Lastly, bottled water being more of a focus because of its use, and that includes microplastics, which Amari will be going over. So, despite having a lot of regulations in the United States and globally on drinking water, there are regulatory source challenges. And those include no regulation for private wells, with about 15% of Americans fitting that bill. The standards varying by country, which makes it challenging to, even though these contaminants have the same health risks, the standards vary. And testing and violations can also vary by water system size and geographic location. Furthermore, communicating those risks is a challenge, and households often do not know what their water quality results often mean, even though there are standards for communicating that. PFAS is being regulated now for 6 compounds in the United States, and there's more being done, but there's a lot of contaminants that are still unregulated. And the violations do only apply for primary standards. And so things that are aesthetic standards actually are not enforced. At the water system treatment level, there's also challenges. There's huge challenges with removing these emerging contaminants. Detlef's going to talk a bit about that with PFAS and disinfection byproducts. The violations themselves in the last quarter of 2024 in the United States, for example, 159 million Americans were in a water system that had at least one violation out of 20 categories. And you can see there, 22 million from total coliform, 4.5 million from arsenic or other inorganics, 9 million from organics, 9 million from radionuclides, and 25 million from lead or copper. And that's within our existing regulatory system. And within that, we're now focused on all of these water infrastructure updates, which are happening, and there's funding being made, but it's a huge process. The last mile, as Erin noted in the plenary, is really that piping and plumbing, and what do we do? How do we do it, both functionally, and then how does it go back to the regulatory standards? We still have a lack of a health-based standard in drinking water in the US and globally, despite knowing there's no safe level of lead exposure. There's still a lack of required testing at the tap for every tap. We need a future lead-free water infrastructure plan that really gets the lead out of everything. Lead service lines aren't the only thing that contain lead. Even once we remove the service lines, we've seen from our data that there's an allowable level of lead in other fixtures, piping, plumbing, and solder. So we have to address that, and we have to help households that are on private wells. So interestingly, with the usage of more bottled water, we also see that consumers themselves are suspect on a lot of their water quality, and they use the aesthetic idea of looking, seeing, tasting, smelling their water to see whether they think their water quality is good, even though we can't actually see these contaminants most of the time in water. And so it results in most people drinking more bottled water, or more, for example, children drinking lots of juice and soda, even though in many cases that's actually less healthy. So we do have to address the risk perceptions associated with water quality as well. There is a disparity between high-income countries and underserved communities, whereby underserved communities often face these disparities in access to clean water, despite our general availability of advanced infrastructure and regulations. And we're finding more and more that this is focused and differential based on geography, socioeconomic status, and systemic inequalities. And so these issues really need to be addressed holistically to make sure we do have equitable access for all. So Maslow's hierarchy of needs is a psychology principle, and at the bottom of that principle is that we need things like air, water, food, shelter, sleep. And then as you go up, you're able to be your full self, right? Able to reach your full potential. And so if we apply this to water quality, you can kind of see at the bottom of those needs are that we need access to water, number one. Number two, we need access to water that's free from microbiological concerns that will acutely cause distress. As we go up, we have regulated water quality concerns that we need to address. We need to make sure that we don't have violations at the current drinking water systems that we have so that we're providing better water. Then we get to those aesthetic water quality concerns. How do we make people want to drink their water and feel good about drinking their water? Then next, the emerging water quality concerns. How do we address things like PFAS? And then finally, what about the unknown? What about the next PFAS? How do we make sure that we're ahead of the curve and proactive so that we have drinking water that's good for the future, for our children? And then if we move that to Maslow's hierarchy kind of based on water access, it's most important for us to make sure for those pockets of individuals that have no access, we need to get them access. We need to help private well users. We need to help smaller municipal systems that have more challenges, and then larger municipal systems that have challenges because they're in areas with source water contamination, for example, or they're in areas that are increasingly having climate distress, such as the city of Asheville that has unprecedented water quality issues now because of Hurricane Helene. And then largely, even larger municipal systems are grappling with what to do with emerging contaminants. So what we'd like to do today is help to kind of identify and redefine what really drinkable water means from source to tap, that safe, clean water is free from ideally the presence of all of these contaminants, or at least below regulatory standards, from the source to treatment through the distribution system to the tap. Secondly, that we have water that people want to drink, that they feel good about drinking. And lastly, water that is accessible to all people in underserved communities and around the world. So next, I'm going to pass it off to Vince, who's going to be moderating the session. We're going to start with Detlef, and we have a variety of fantastic presentations helping to identify the state of the science for treatment, removal, and destruction of emerging contaminants. And then the next session also is focusing on this topic of protecting water quality, so we hope you'll stay and listen. Thank you.
Great. Thanks, Jennifer. That was great to set stage that way. Appreciate it. Now, welcome, Detlef Knapp. Dr. Knapp is the S. James Ellen Distinguished Professor of Civil, Construction, and Environmental Engineering at NC State University, and has been there since, I think, 1996. And in addition, he's a Deputy Director of NC State's Superfund Center, Environmental and Health Effects of PFAS, and is a member of NC State's Center for Human Health and the Environment. So, welcome, Detlef.
Thanks, Vince. All right. Get to do this fast. So let me see. There you go. Here we go. So I'll talk about PFAS. And PFAS are a class of synthetic chemicals. According to EPA's PFAS structure master list, there's almost 15,000 PFAS structures that have been identified. And these PFAS fall into different categories, some of which we know quite a bit about in terms of toxicity. Some we're just discovering and know very little about. And then there are also fluoropolymers that are often treated as a separate subclass. And we're concerned about PFAS for a number of reasons. Many PFAS are persistent, and that gave them the moniker also of forever chemicals. Some PFAS are bioaccumulative, and so half-lives in people can be quite long, in the order of months to years. And many PFAS have been shown to be toxic, including to the immune system, the liver, and also causing cancer. And another concern is that a number of PFAS are highly mobile, so we find them really throughout the world, even in very remote regions. PFAS enter the environment through multiple pathways. We have primary PFAS producers. The PFAS from these facilities then get often shipped to facilities that incorporate PFAS into products. And then we all purchase products and use these products. And then in all of these steps, there can be emissions to the air, to the water. There are solid waste streams, and so PFAS end up in landfills. PFAS end up in wastewater treatment plants. PFAS end up in the air. Through dry and wet deposition, they come back to the ground, contaminate the groundwater. Wastewater treatment plant discharges can contaminate drinking water sources. Residuals from wastewater treatment plants get land applied, incinerated, or put into landfills. And so we also start setting up these cycles where PFAS get just moved around from compartment to compartment, and it's very important to break this cycle. PFAS have been found in very many drinking water sources and finished drinking water. So this is a map from the Environmental Working Group that shows known PFAS contamination around the country as of August of this year. And all the lighter blue dots are places where the EPA drinking water standards for PFAS are being violated. And according to EPA estimates, somewhere in the order of 5,000 to 6,000 public water systems have to treat for water because the source exceeds the standards. And that will impact about 100 million people in the United States. So you can also see the very large widespread impact PFAS have had through these variety of sources that cause water pollution. As Jennifer pointed out, apart from private water systems, also, public water systems, private wells are also impacted. And so here's an example of a PFAS manufacturing site here in North Carolina. And these are thousands of private wells, each dot that are contaminated with PFAS. Wells that are 10, 20 miles away from the facility are still contaminated. And as of October of 2 years ago, about 6,500 homes were eligible to receive some kind of intervention, either whole house filtration or under sink reverse osmosis systems. So I'm here to talk about treatment, and so in this chart provides some options for treatment, and so boxes that are encased in black are concentrating technologies, so they remove PFAS from water, but they don't destroy the PFAS. And then boxes that are sort of surrounded by this Carolina blue are destructive processes, so they actually destroy the PFAS. And of the processes that are practical for water treatment are primarily these concentration technologies. So we have technologies like high pressure membranes, so reverse osmosis or nanofiltration, granular activated carbon adsorption, and anion exchange resin beads. All of these can remove PFAS from water, but they don't destroy PFAS. In addition, there's a variety of novel sorbents that are being developed with the goal to make these sorbents more selective for PFAS or micropollutants in water. So some of these are amine-modified clays. So there's a product called Fluorosorb. There's cyclodextrin-based polymers that have cavities where PFAS fit very well into that cavity. So there's one commercial product right now called Dexsorb and others that are being developed like Stydex. And also ionic fluor gels are being developed here at UNC Chapel Hill as one option to selectively remove PFAS from water. So when we look at activated carbon and anion exchange processes and also some novel sorbents, these are put into large vessels and water basically flows through those vessels. And there's some common features to how these technologies perform. So just to show you this, there are graphs for 4 different PFAS here: PFOA, PFOS, PFHXS, and PFBS. The x-axis is time or bed volumes of water treated, and the y-axis is the PFAS concentration. So if we just pick a PFAS like PFOA, but it's the same feature for all of these, there's a period of time where these treatment systems completely remove PFAS from the water, right? And then as PFAS and other stuff accumulates on these sorbents, their effectiveness goes down, and we say the PFAS are breaking through the system, right? So the concentrations start going up. So the most effective sorbents would be the ones that are lasting the longest. So here, one of these ion exchange resins in purple is very good, and then this novel modified clay is very good. In terms of destructive technologies, we have a variety of tools: incineration, thermal reactivation of activated carbon, supercritical water oxidation, hydrothermal alkaline treatment, and a number of others. And so some are at a high technology readiness level, like granular activated carbon thermal reactivation. Others are still more under development, but available already for pilot systems, at least, like this supercritical water oxidation system that's being developed at Duke University. And so when it comes to PFAS destruction, one thing that is important to recognize is we're not just looking at is a compound like PFOA going away, but are we really mineralizing the PFAS? Are we converting it all the way to fluoride? And so you can see here with the supercritical water oxidation system at lower temperatures, there's still a lot of organic fluorine, and only after you get to these higher temperatures do you convert most of the organic fluorine to fluoride. And almost done. So we also are interested in, are these destructive technologies emitting products of incomplete destruction to the air? And here again, we see at some of the lower temperatures, there's volatile and semi-volatile PFAS that can leave the system, whereas at higher temperatures, they basically are fully mineralized. And so the challenges, PFAS definition, there are competing definitions of what PFAS are. We can talk about that later. Other things, analytical methods, current standard methods capture only a very small portion of the PFAS that are out there. There are precursors that will be long-term sources of PFAS. PFAS toxicity remains largely unknown for many PFAS, and routes of human exposure other than drinking water are also largely poorly understood. For PFAS destruction, we need to understand products of incomplete destruction and energy intensity. And also, very important challenge is the source control. PFAS continue to be incorporated into many products. Many of us purchase these products without knowing that the PFAS are even in there. So with that, I'll stop and turn it over to the next speaker.
Thanks very much, Detlef. That was wonderful. If we have time at the end, and you had a question maybe for Detlef and PFAS, please save that. If we have some time at the end, we're going to open it up and have sort of, question session then. So now I get to welcome Dr. Mike Fisher, an assistant professor in the Environmental Sciences and Engineering Department at UNC, and a senior research fellow at UNC's Water Institute. So welcome, Dr. Fisher. Come over.
All right. Well, thanks, Detlef. That was great. I really don't want to follow that with something as simple as toxic metals in drinking water in high-income countries, only because I think we all have a pretty good understanding of a lot of what's going on with toxic metals in drinking water. But I wanted to highlight three that are of interest because I think there are nuances with respect to occurrence, exposure, health effects, and management where we really do have new and useful evidence that can help us maybe do better in high-income countries going forward. And so, there's a wealth of things we could talk about, but I wanted to sort of zoom in on lead, manganese, and arsenic as ones where there may be a bit of a twist in each of these stories that could be useful. So with respect to toxic effects of lead in drinking water, these have been well understood for a long time, both in terms of cardiovascular outcomes affecting people at all stages of the life course, but also maybe most critically, neurodevelopmental and cognitive impairment that particularly affect vulnerable life stages, infants and developing fetuses, and can contribute to irreversible lifelong burden of disease, even at very low levels of lead exposure. And so that sort of leads to the conversations around, we really don't have an identified safe level of lead exposure, but lower is better. And lower than our current regulatory guidelines is still much better. We've been making great progress on lead in this country and globally over recent decades. I apologize, this isn't as big as I thought it would be, but I think we all know the broad strokes of elimination of lead in gasoline and paint around when I was growing up, and progressively making progress eliminating lead in the solder that we use for canned food and other sort of food system sources. Lead and copper rule initially in the 90s with an important update just recently in 2021, as well as saying, hey, let's not put components with lead in drinking water systems on purpose, right? So going from parts in water systems can be pure lead to they should probably be less than like 8% lead to now, we really require them to be less than 0.25% lead. And, increasingly we're applying NSF 61 where they shouldn't leach lead into the water no matter what mass fraction is. So we're making great progress there. And so the question is, okay, have we solved lead in drinking water? Can we neglect it if we just do all this stuff? And, again, when we look at evidence synthesized by the American Academy of Pediatrics from studies over the last couple of decades, we see that lead in drinking water still contributes a non-trivial proportion to children's blood lead. So, the evidence says we have not yet reached the point where we can neglect lead in drinking water. And so the conversations about, okay, let's not make it legal to put lots of lead in our water systems on purpose, check. Let's, require good corrosion control for public water systems, like we heard about, from Dr. Redman, check. But there's still more we can do. And so I think there's important conversations both about what we can do in community water systems, but also, and I apologize that this is small, but here's some data from Wake County that basically the takeaway is when we look at odds of elevated children's blood lead level between folks on community piped water and folks on private wells, we see significantly higher odds of elevated blood lead for folks on private wells, even after controlling for all the other things that you'd want to control for, like, age of the home, socioeconomic status, and all these other confounders. We see, folks on private wells, much greater risk of irreversible harm. And our system for catching that is child blood lead screening, which happens at age 1 or age 2 if you're lucky. But when we look at data from Chicago, we see that there's disproportionate under-capture of childhood blood lead data for precisely the most vulnerable populations. And so when we look at the graph of where do we see the highest occurrence of lead in drinking water in Chicago, that overlaps with also where do we see the highest proportion of minority populations, and where do we see the highest proportion of kids who are getting missed by that childhood blood lead screening. And so, I think we can still make a case that we've got a long way to go for continuing to improve outcomes for all children with respect to lead in drinking water, and reducing disparities in terms of who benefits from the available solutions to prevent that harm. So, that's sort of one aspect of lead in drinking water that hopefully is thought-provoking, even though this is not a new topic. With respect to manganese, we've known for a long time that at very high levels, manganese can be toxic. And high levels of manganese exposure, again, can contribute to impaired motor coordination, dexterity, verbal ability, total IQ scale, general neuro and cognitive development in children. But we're increasingly learning that lower levels of manganese in drinking water than we were previously worried about are still associated with some of these outcomes. And so, whereas previously WHO said 400 micrograms per liter, which is kind of around the point where it starts to taste funny anyway, WHO is now putting out provisional guidelines of maybe we should be below 80 micrograms per liter. Health Canada is looking at below 120 micrograms per liter. EPA has a health reference level that's not enforceable. But, again, we're learning more about the hazards of manganese in drinking water. And when we look at occurrence of manganese in U.S. water systems, a lot of groundwater and even some surface water systems are getting up to or exceeding some of those WHO guideline values or Health Canada values, suggesting that, again, there may be opportunities to do more around manganese in drinking water. And of course, those hazards are going to be non-equally distributed because the manganese is geogenic, right? It's there in the subsurface as compared to the lead, which if we just stop putting it there, we can solve the problem in 20 to 30 years. And then I'll go quickly, but arsenic, I think we're all familiar with the fact that at high concentrations, arsenic can be acutely toxic in a number of ways, and even low chronic exposures can contribute to cancers. And we know that arsenic, again, is geogenic in drinking water. So if you're on groundwater in some of these darker areas, your groundwater has naturally occurring arsenic that can be removed by available engineering technologies. But if you're on a private well, there may not be a whole lot in practice between you and arsenic in these regions. And what we're increasingly learning from research from folks at UNC and others is that arsenic can contribute not just to acute toxicity and carcinogenesis, but there's also epigenetic effects of arsenic that can affect even pregnancy and birth outcomes, even very early in the life course. And so the more we can learn about the effects and prioritize prevention, potentially the more we can do. And finally, I'll just end by saying we're learning more about these hazards individually, but we're also learning more about their importance in combination. And it turns out that metals mixtures have additive and potentially harmful synergistic effects in combination that are not always apparent when we just look at the effects of individual metals. And so increasingly we're learning that these as well can be really important for understanding how to improve pregnancy and birth outcomes. And so I think we can make a strong case that even though we've known for a long time that these chemical hazards occur in drinking water sometimes at levels of concern, we're really just diving into a better understanding of what we need to do, where, how, and to what extent to optimally protect human health for populations broadly and reduce disparities when we have these double, triple, and quadruple failures to protect the most vulnerable populations from these exposures. So not trying to be a bummer, but hopefully food for thought there that as we have better evidence, we can hopefully turn it into useful evidence-based practices to move the needle on those things. Yeah, thanks.
Huh? Oh, that well, he did it already. I'm sorry. Yeah, okay. Thank you very much, Mike. Welcome, Dr. Heather Murphy. Dr. Murphy is an associate professor and Canada Research Chair in One Health at the University of Guelph, and previously was at Temple University, where she's still an associate research professor there and leads the Water Health and Applied Microbiology, or WHAM lab, and I'm very jealous of that acronym. It's a great acronym, where her research focuses on microbial quality of water and health. So welcome, Heather.
Thanks, Vince. Thanks, everyone. I'm going to switch gears and go back to microbes, where I do most of my research. So for those who aren't familiar, I'm going to go over very quickly the common waterborne microbes that we're concerned with in high-income countries. So we have viruses, which are the smallest microbes. Then we have bacteria, which are bigger than viruses. And then we have protozoa, which are even larger than bacteria. So what do we know about waterborne disease in high-income contexts like the United States? Well, actually, the sources of waterborne disease are not really well defined. And so why is that? Well, we have not all these illnesses are linked to outbreaks where we have great surveillance. And so we have what we call endemic and sporadic cases of disease that go isolated and they're underreported and underdiagnosed. And so for those who aren't familiar with underdiagnosis and underreporting, I'm going to go through a little activity here. So if we look at the top of this triangle, that's the amount of illness we can measure through our surveillance system. But the bottom of the triangle is what we actually think exists out there. And so if I were to ask you all, who had a case of diarrhea in the last year? I'm going to put my hand up. I'd like everyone to put their hand up and be honest. Okay. For all of you, how many of you went to the doctor? Put your hand up if you went to the doctor. I lost you all to the surveillance system. So if one of you actually went, then how often does your doctor actually prescribe to go get a stool test? And then how many people are not grossed out enough to actually give that stool sample? And then how sensitive are our laboratory tests, and so on and so forth. So we lose all these cases. So the CDC and other agencies, including the Public Health Agency of Canada, have been trying to come up and wrangle, like, what is the true burden of disease? So there's some recent estimates that have come out. And so the recent one from the CDC includes all waterborne exposures, and they use surveillance data and expert elicitation for 17 waterborne diseases. And overall, they estimate around 7.15 million waterborne illnesses annually in the United States, which resulted in 600,000 emergency department visits, 118 hospitalizations, 6,000 deaths, almost 7,000, and 3.3 billion in direct healthcare costs. In terms of what we know about burden of disease globally, we did a systematic review, and to be honest, it's pretty sad. The highlight is we don't know very much, and we even looked at other contaminants, like who has quantified the burden of disease, and there's these huge gaps. And one of those gaps is private wells and emerging contaminants of concerns, which all my fellow speakers have been speaking about today, but microbes are also a problem in private wells. So I'm going to summarize briefly the gaps in our knowledge on waterborne disease in high-income countries. And so where I see them the most is firstly in kind of underserved indigenous communities or rural locations. So those communities are certainly at risk. Then private wells, so you can see a well there. Recreational water, I know that's beyond drinking water today, but recreational waterborne disease. And then our drinking water distribution system and premise plumbing systems. And so in terms of recreation, there's still a lot of people globally exposed to what we call combined sewer overflows in urban water settings. So even like the Seine in the Olympics, people were being exposed to raw sewage being overflowed into waterways. And so the US EPA estimates that 1.8 to 3.5 million people become sick from swimming in these waterways. And this is actually a picture of 2 children in Philadelphia, where I used to work, in a combined sewer overflow impacted stream, recreating. And they live close by to this stream, and there's a lot of underserved populations that can't go to a public pool, and then they're recreating in these waterways. And so we did some different risk assessments, and we showed that really the risk exceeds the US EPA guidelines of 30 illnesses per 1,000 recreational events in these waterways. So moving on to private wells, well, how do they become contaminated with microbes? Like, some of the main contamination sources are septic systems, and then we got agricultural activity. So those are kind of our main inputs of pathogens into well water. And the more research we do, the more we find that these pathogens make their way into water where people had thought that they did not. So this is work from a colleague in Wisconsin, where they found 60% of wells sampled had fecal contamination, and they sourced it back to dairy manure and septic system waste. There's even more recent evidence from the same research group that showed in Minnesota that 40% of publicly supplied water wells had cryptosporidium, which really shook up, I think, guys at the EPA, because groundwater is not can be disinfected with just chlorine, and cryptosporidium is resistant to chlorine. They also found human sewage markers, so human bacteroides, in 21% of wells they studied in Wisconsin, and 15% of wells were positive for rotavirus. And these data are similar to what I see in Pennsylvania on some unpublished research that we have going on. And then some people are like, well, everyone's on a deep well. Well, even deep wells are at risk. And so that's a common misnomer. People are like, oh, my well's really deep and therefore it's safe, which is just not the case. So what's the burden of disease attributed to private wells? Well, there's no robust estimates that exist, and I've been dying to find the answer. There's really few population-based studies, but some work I did in Canada at the Public Health Agency of Canada, we estimated around 70,000 cases of illness due to private wells annually, which if you look at the US, that works out to around 1.3 billion cases. And that's kind of like the best estimates we've got right now. But I'm currently doing a randomized control trial in the state of Pennsylvania to look at what is the burden of disease due to drinking water from private wells, and we're randomizing households to a UV water treatment device or a sham device to compare illness rates. Lastly, I want to talk about the distribution system. So this is a quote from, it's an outdated report, but I still think it holds true. The distribution system is the remaining component of public water supplies yet to be adequately addressed to national efforts to eradicate waterborne diseases. And the reason being, we have our aging infrastructure, which we've heard lots of people talk about today, as well as main breaks. And this is a bit of an older study that was done in Europe, and they saw a 37% increase in acute gastrointestinal illnesses following exposures to main breaks or standard maintenance in the distribution system. And the CDC has just completed a study, and I'm waiting for the results to come out of any day now with a similar study. We also have opportunistic pathogens that are found in like the premise plumbing of people's homes. And so actually the estimates that came out of the CDC showed that 88% of hospitalizations and 98% of deaths associated with drinking water exposure were due to these biofilm associated pathogens. So mycobacteria, Pseudomonas, and Legionella, leading to around 1.1 billion costs annually. And so there's lots of different interventions and people working in this space to try and eradicate these premise plumbing pathogens. But one thing I wanted to highlight from our work is we found that pipe material really mattered in which organisms colonize these different pipe biofilms. So in summary, advances in sanitation water have significantly reduced our burden of disease in high-income countries, but more work is needed for private wells, small water systems, First Nations, Indigenous, and underserved marginalized communities, as well as our drinking water distribution systems and premise plumbing systems. And there's some acknowledgements. There's a lot of people that have funded my research and team that I work with. Thank you.
Oh, these are extra slides. Got it. Thanks very much, Heather. Really appreciate the foray in infectious diseases, since that's what my program at CDC focuses on, so I appreciate that very much. But now back to chemicals in the environment and other issues. So Dr. Mari Walker-Franklin, welcome, is a research chemist at RTI International and contributes research to determining human environmental exposure to potentially harmful substances. So thank you and welcome, Dr.
All right, hello everyone. It's great to be here today. Again, my name's Amari. I'm a research chemist, but my background's environmental engineering, so I'm really enjoying all of this. So today we're going to talk about microplastics, which is slightly different in many ways, but all related to the previous talks before. So first, we'll just start off with what is a microplastic? Well, it's pretty easy. It's just a small piece of plastic. And plastics in general, we know they're ubiquitous in just everything that we do and see to this day. Whether it is as thin and flexible as a film on a TV dinner tray or as, durable and rigid as a drinking water pipe, we can see plastics in just about everywhere. Microplastics are really just plastics that are smaller than 5 millimeters. Sometimes science says below 1 millimeter. And then nanoplastics, which is also a new emerging topic, are things smaller than a micron. So if we're thinking about sizes, we've got nanos that are really around the size ranges of bacteria and even viruses at this point. So when people say, do plastics really go away? It ranges. It could take hundreds of years to thousands of years, and in that process, it's turning into microplastics and nanoplastics. And then eventually, we hope it'll mineralize into CO2 and water. So we can see that plastics can take on a variety of sizes and shapes, whether they're spherical to fragments, fibers, and films. Not only do they come in ranges of colors, they also have so many different kinds of additives that are placed within them or processing aids, and that really just changes the property of the plastic itself. Microplastics can be primary in nature, where they're intentionally made that small, so plastic pellets that are used to make plastics, to microbeads that are put into cosmetics, or even paints, industrial paints, to secondary microplastics, which is the larger majority of microplastics that we find in the environment and just in the areas that we are in. So secondary microplastics usually are formed via either abiotic processes, such as exposure to water to hydrolyze the surface, exposure to air and temperature to oxidize the surface, and then even mechanical abrasion, which is just like an ocean wave hitting a water bottle, to grind and break apart those plastic particles. And then biotic factors like microbes or even other enzymes can also be another route of degradation. So if you see a chair that sat out all summer, it's starting to crack and become brittle, it's releasing fragments, and microplastics are also, of course, being released, along with these polymer-associated chemicals that might also be of concern. So there's many different places these microplastics could be released. Some are, from just from manufacturing itself. Some is from, just everyday use. The moment you wash your clothes, a large majority of our clothes are actually plastic. They're releasing microfibers to personal care products that are used that have microbeads, or even the moment that we drive to get to a place like this conference, we're releasing tire rubble as also a microplastic into the surrounding environment. From the moment that we're done using these products, disposal routes are also releasing different kinds of microplastics, whether we're open burning these plastics to just letting them sit in a landfill, or mismanaging waste that ends up in the environment. This also leads to the release of microplastics. So when we think about microplastics in the environment, like the ocean, or even just general waterways, a large majority of them end up being synthetic textile in nature. So a lot of them are microfibers. Following a decent majority are also from car tires and just general city dust. So these are a lot of fragments and film particles. So why are we worried about microplastics in particular? Well, there is the idea of it being toxic just inherently because of it's a particle surface charge, its morphology being jagged and edged, depending on where you are, where this microplastic is located, and then the size, if it's small enough to end up in different parts of the body, like the brain, which we've seen before. We also know that microplastics can host pathogenic bacteria and viruses and act as a vector of transport. And these plastics also have other chemicals inside of them. So we know the most recent estimates are that plastics are associated with about 16,000 different chemicals that could be used inside of them for monomers, processing aids, or even unintentionally added compounds. And so some of these compounds include PFAS, are also incorporated into plastics. And these are not bound to the polymer, so they have every opportunity to be released into the air or water or the surrounding environment that it's in. Additionally, these plastics can absorb other heavy metals or other persistent organic pollutants and continue to be this vector of transport for all of these items. So we do have some worries about plastics and human health, though some of these are still being widely studied. We know we can find them in just about everywhere we look in the human body. And we can see them in the brain, we see them in the placenta now, and we're worried about what the possible harms are. So some of the most recent studies have shown increased microplastic concentrations in the arteries led to increased risk for stroke and heart disease, along with correlations to inflammatory bowel disease, and then low male fertility has mostly to do with the polymer-associated chemicals themselves. So what does that have to do with water itself? So we know drinking water does have microplastics. However, it's mostly bottled water that has, thank you, higher concentrations of microplastics. So we know that we are likely to drink or consume around 50,000 particles per year of microplastics. However, that number when we think about nanoplastics is actually increased far higher now. There's around 240,000 nanoparticles per liter. That was one of the latest reports in water. And yeah, it really does depend. If you're drinking bottled water, there's far more exposure. But if we think about our typical drinking water methods, most of them are removed commonly through these drinking water methods. So, if you think about from coagulation to sedimentation, more than half are removed. To filtration, another half of that is removed. And then the final treatment process will remove another decent amount. So it could be anywhere from 80% to 90% of microplastics are removed. And really, some of these treatments also could be hindering versus helpful. So sometimes UV treatment can increase microplastics, which I showed before. Abiotic factors can increase microplastic release, along with ozonation as well. And it can be a challenge as well for drinking water plants. It can hinder coagulation. It could increase membrane fouling quicker. And then even disinfection. It could protect the bacteria from being disinfected, or it could absorb the disinfectant and hinder these processes. So we'll kind of just throw away the takeaways that we know a lot about microplastics. We don't know a lot about nanoplastics. So there's still a lot we have to study as far as removal of nanoplastics. But a decent amount are currently removed through our tap water, drinking water processes. And if we think about wells in particular, they're not well studied. We know there are microplastics in groundwater, but we don't know how well they're actually being removed with the techniques that are commonly used. And drinking water is a huge source of microplastic consumption. And so we have to worry about that for human health, but we have to do more investigation. And we'll stop. Cool. Okay. Oh, and I forgot to say, I wrote the book Plastics. I have 3 books up here. If you all want at the end of the session, I'll give it to you.
Wow. She literally wrote the book. Wow, that's fantastic. Thanks so much, Amari. Well, I want to commend all our speakers on doing an amazing job of presenting a lot of dense and complicated and new information. I really appreciate it. We do have time for if anybody has a question for anybody on the panel, and I can bring you all the microphone. Yeah, why don't you all come up? Does anybody have a question? Yeah, please.
Hi, my name is Jason Brooks, and I work for an international NGO called Global Communities, but we also work domestically in the southwest of the United States with a lot of low-income communities. And I just wanted to make an observation, since we're doing some comparisons between international development and domestic work and high-income countries, is that the populations we serve in Southern California through mother and child health programs, many of them are immigrants. We conduct our programs in many languages, et cetera. And one thing that we did not discuss was about confidence in our water systems. So this is a direct response to questions I received from project managers. They said, our young mothers are not consuming water, and they are not preparing bottles with water, not because they have heard about contamination in U.S. water systems, but because the places where they come from, they would never consider drinking the water. And I'm just curious, as there's increasing information about water quality, how do we avoid a situation where we actually have the human impact of low consumption of water because people are afraid to use it? And at the same time, these low-income, families are asking, Jason, what kind of water filter should I be using? And I hesitate to really relate to them that they can't afford, in many cases, the kind of water filtration that would make their water safe to use for preparing their child's bottle.
Thanks very much for that question. Really interesting. Yeah, anybody on the panel want to answer?
And it's lots of layers to the question. I think with respect to the last point, one concern I always have is that people quickly resolve to purchasing bottled water as the solution, and an under-sink reverse osmosis system will take out pretty much everything. It will make drinking water pretty much out of the nastiest water. And while they cost about $200 to purchase and maybe $100 a year to maintain, that's a lot cheaper than buying bottled water. So I think conveying confidence in systems like those, and there are some that are cheaper that can work well for many different situations, could be one way to communicate that people can trust at least the water that goes through those filters. And I think communicating that water is essential both from a hygiene and human intake perspective is the hierarchy of needs that Jennifer presented was, that's the first level, right?
Thanks, Dylan. I think I see Mike itching to jump in. Go ahead, Mike.
Yeah, I would just add one thing, and at the risk of academic trespassing, because I'm not a behavior guy, I guess in my very limited experience, information doesn't change behavior as often as nerds like me think it does. And so, to unpack that a little bit, I think there's kind of a three-part story where, number one, how do we make that true for everyone in the U.S. that the water is safe to drink? Number two, how do we do effective risk communication in time, in the appropriate language, and maybe not from a nerd like me, right? Maybe from your OBGYN or your personal care provider or somebody else in the community who has earned your trust. And then number three, where we have historically broken trust with populations, that doesn't come back in one generation. And so how do we sort of progressively reduce disparities in terms of statistical risk, around health and safety, but how do we also do a better job of rebuilding trust? And I have no good answers to that, but hopefully I've complicated the question.
Thanks. Yeah, go ahead, Heather.
Yeah, I can add just a little bit. What Mike said, I can echo. We work with pediatricians in Pennsylvania to try and give advice back to homeowners. They're trusted sources of advice for their private wells, for example. But also, I work closely with the Philadelphia Water Department. I didn't work on this particular project, but they had the same issue where there was distrust in the public water system, and they did huge campaigns, and they actually bottled city water and gave it out to try and encourage people to trust the water, particularly in low-income communities, because they were buying soda, and then there was a soda tax that went in, and there was the obesity rates were going up in the city, and so they were trying to work with public health to combat that. So there's a pretty good case study of Philadelphia regaining public trust, so you might want to look up some of the risk communication work that they did there. Yeah.
And thanks very much. Thanks to all our speakers, and thank you for that question that helped integrate across the panel here. I appreciate it. And I think we're done, so thank you all for your time. Appreciate it.
Hello, hello. Just a quick reminder, we'll be starting phase 2 of this session in a few minutes, so we'll do the transition and get people in here.
I think there's a global movement
don't tell me about MCLTs. Okay, good.
So I think in certain product categories, it's starting to become palatable.
Oh, and
PFAS are contact materials.
I could not agree with you on that.
But,
Out of
but
10
I
labs
think
with the instrumentation,
broader sense, nationwide,
we got 0. And then we got
for chemical use pushes a lot for
domestically and globally, what's working.
So,
Labs sort of to the frontier of its performance.
it's going to be very challenging. I think the problem is not as maybe obvious as those in control, skin cancer and burning out.
Sure, but that's all.
It's more subtle. But I think the movements are there, right? The Great Science Policy Institute is really
We're not going to regulate a particular task because it's a widely variable. We're going to regulate the quantity of the distribution. That is more protective than saying, here's the number, and that's the number forever. So it's there. That's a good point. I always try to say, when I teach the class, I always try to say, there's no number where when you're at 0.99 of that number, you're good, and you're at 1.01 of that number, massive risk. But I think that's an important thing that I don't I'm always trying to say, you never could pick a single binary threshold.
Great. Well, thank you for coming back for part two. I know there's still people lingering that will be coming in shortly. We have a great opportunity right now to hear, we had the first session really talked about the science behind, contaminants in water, how it's impacting, high-income countries and what we can see and how we're going to address these moving forward. This next panel is to really focus a little bit differently, to focus on how we can make those changes, from a policy level, from an advocacy level, from other areas of, some of the premier experts on what they're doing now and how we can all kind of jump on board to make the changes based upon the science and other information we've heard today. So I'm going to turn the time over right now to Chuck Chadovitz with the U.S. Chamber of Commerce, and he will be able to kind of take us through today's panel and through the discussion as we head throughout the day.
Thanks so much. Can you hear me now? Okay. So thanks so much, Dane. Really appreciate it. I think that we want this to be a little bit more engaging with you and to have you discuss these issues with us. This is a really challenging opportunity for us to hear from you. So I want to thank Aaron and the Water Institute for including the Chamber in this important discussion. Thanks all of you for coming. It says a lot regarding the importance of this issue that you're hanging in here on a Friday morning. High-income countries has never been part of the discussion here at the Water and Health Conference. I was to the first one of these. And so, last year was the first time that we had a side event on these issues. And so to have a full day dedicated to access to water and sanitation here in the United States and other high-income countries around the world, really important. The Chamber, as you may know, is the largest business trade association in the world, representing companies of all sizes and sectors. And we have active members who have great interest in issues around water and emerging contaminants. As the administrator alluded to, we were big supporters of the transformational funding in the bipartisan infrastructure law, among which contained $5 billion for small and disadvantaged communities to address emerging contaminants, including PFAS. We, along with others, and we presented this last year, developed a roadmap to help access those funding to those small and disadvantaged communities, the best of both public and private technical assistance. EPA has, and we might hear about that a little bit, has released unprecedented amounts of funding for technical assistance for communities, but often the most vulnerable don't have the wherewithal to access that. So really important discussion that we need to have on that. I think we need to ask ourselves the question, and I think Aaron alluded to it this morning, is it okay here in the wealthiest country in the world that we still have 2 million people that don't have access? And then even more than that, the water quality issues that we'll talk about today, millions more don't have access to water quality that they deserved. The business community supports accelerating cleanup of emerging contaminants and particularly PFAS in the environment based on the best science and risk. We've had many discussions with our colleagues at EPA regarding how best to do that. At the same time, and this was alluded to in some of the presentations earlier, we believe we need to maintain access to some of the essential fluorochemistries that Americans use in products every day, and that's everything from medical devices to cell phones to automobiles and aircraft, and then to all those technologies that we rely on for the energy transition that the administrator talked about, important to addressing issues regarding climate change. All of them have some element of PFAS in them. So this is a really complex issue where supply chains make some of the regulatory approaches being proposed very, very, very challenging. So let me introduce our panel. We're going to ask a few questions. They have a few slides, and then we'll ask a little bit more. I think we'll go maybe 20, 25 minutes regarding that, and then we'll have about 10 or 15, maybe 20 minutes to hear from all of you. One thing that I've really appreciated about the Office of Water is that even when we don't agree on everything, the doors are always open to come in and talk about those issues. This is definitely one that has been particularly challenging to engage in. So first, I want to introduce Eric Bernison. He's the Director of Standards and Risk Management Division at the Office of Water at EPA. He's the person who has really been the tip of the spear on the National Primary Drinking Water Standards on PFAS and some of the other issues. And so, Eric, want to start by talking a little bit, how does EPA identify and prioritize contaminants and for regulatory consideration?
Thank you, Chuck. Appreciate that introduction. Appreciate the opportunity to be here. I want to thank the Institute for convening this special track today. And I also, Chuck, want to thank you for all the interactions we've had over the years on some of these tough regulatory issues that we address. So I want to set the stage a little bit, talking about the authorities of the Safe Drinking Water Act, which is the enabling legislation for the EPA in addressing some of the actions that the administrator talked about this morning. And I'll take a cue from my boss, who talked about the fact that the agency has to measure twice and cut once. I probably would have corrected his talking points and said maybe you have to measure 1, 2, 3, 4, 5 times before we actually can make those cuts. So the Safe Drinking Water Act sets out a fairly elaborate, data-driven process that has both public input and consideration of a number of factors, including science on the occurrence, health effects, and treatment available to address contaminants of concern. So I'll talk briefly through this multicolored chart that doesn't have the poop emojis that Heather brought to bear in the last session, but I'll try to make it somewhat as interesting. So we follow a process that's cyclical in nature and, as I said, driven by data. It starts on the left-hand side of the chart with something called the CCL. We're going to have lots of acronyms. I'm a government bureaucrat, so you're just going to have to deal with that. The CCL stands for Contaminant Candidate List. That's a list of contaminants that may occur in drinking water and may require regulation. We have to do that every 5 years. We're on our 5th cycle right now of the CCL. We've got 66 individually listed contaminants, and then we've got several groups, including all PFAS. Included on our current CCL list. We're actually in the process of developing our 6th CCL, which we'll be publishing in this next year or two. We have the next acronym on the alphabet soup up there is the UCMR, Unregulated Contaminant Monitoring Rule. Also on a 5-year cycle, in which we require water systems across the country to measure for the presence of up to 30 unregulated contaminants in drinking water. It is a census of, right now, it's a census of all the systems serving 3,300 or greater. And in most years it has been actually a census of all the systems serving 10,000 or greater, and then a representative sample of smaller water systems. Purpose of that process is to get a handle on the frequency and level at which these unregulated contaminants occur in public water supply systems nationally. It is designed to give us information that we could use to then consider in our subsequent regulatory steps, including whether or not we want to put it on our list, or in the next step of the process, regulatory determinations. So also on a 5-year cycle, the agency must look at our CCL, look at the data we have collected from the UCMR and other sources of occurrence information, and make a determination as to whether or not we are going to regulate. The statute lays out a minimum of 5. We have to make 5 determinations every 5 years. There's no maximum associated with that. The agency has in most cases done more than we have to do. The criteria that we have to use to make a determination is is the contaminant known, or may the contaminant have adverse effects? Does it occur, or is it substantially likely to occur with frequency and level of public health concern? And then the third criteria, in the sole judgment of the administrator, the guy who spoke this morning, in the sole judgment of the administrator, there's a meaningful opportunity for health risk reduction for persons served by water systems, right? So those criteria, the answer has to be yes to all 3. And to satisfy those criteria, we need robust data on the toxicity, on the occurrence. To know whether or not it occurs, you have to have an analytical method to measure for it. And then we also, if there's a meaningful opportunity, one of the things we've always traditionally looked at, is there something that a water system can do to remove this contaminant? So those are the factors that have come into play. And those are the factors that came into play as the agency decided to regulate PFOA, PFAS. We made determinations to regulate those contaminants back in 2021, and then we also made additional regulatory determinations for different additional PFAS as a part of the rulemaking that we did for the PFAS. So once we make a determination to regulate, or at the same time that we are making a determination to regulate, we then move into a national primary drinking water rulemaking standard. I'll talk about how that process works a little bit in the next slide when Chuck asks me the next question. But then I would say once we've issued those standards, we're not done in perpetuity. The statute makes us go back and look at all those health-based standards. Right now we have basically over 100 different national primary contaminants regulated. Some of them are very broad, like viruses. or radionuclides, which is why we actually literally have hundreds of contaminants that are technically regulated, however not all named. We're required to every 6 years, it's the one, doesn't hit a 5-year cycle for this one, every 6 years we have to go back and review all of our standards and determine if a revision is appropriate, and there is a anti-backsliding provision in that 6-year review standard such that any revision must maintain or improve public health protection. So that's a little bit of an overview.
So why don't you go to the next slide? And how does EPA develop regulations that can be implemented by public water systems in the states?
Okay, thanks, Chuck. It's like we rehearsed that or something. We work very well together, don't we? So once we've decided to issue a standard, the Safe Drinking Water Act lays out yet even more measurements that we have to make before we make that cut, to use the administrator's metaphor today. Once we've started a rulemaking process, and the statute dictates we have 2 years to do all of these things, once from the point at which we make a determination of regulated contaminant. We need to use the best available peer-reviewed science and data collected in accordance with accepted methods. So it is again driven by robust scientific information that has to be used, and among other things, we have to consult our science advisory board and a number of outside groups to seek input to assure that we're using the best available data and addressing concerns. We have to establish a maximum contaminant level goal, which is a non-enforceable standard. It's set at the level at which there are no adverse effects on the health of humans with an adequate margin of safety. It is a standard that then informs our health-based standard. And I'm going to disagree with some of my prior panelists. I've told Mike at least that I was going to do this. Jennifer, I'm going to disagree with you as well. We have health-based regulations for all of our drinking water standards, including lead. I think what Mike and Jennifer were alluding to was that for a contaminant like lead, which has high variability in terms of the concentration which is present in any location within a system at any particular time, we chose an approach called a treatment technique, which is designed to reduce the levels of lead to the maximum, to the extent feasible. People often misunderstand our action level for lead, which is not a health-based standard. Let me agree with you both there. But it is a part of a regulation which is health-based in that it is designed to reduce levels as low as feasible, as close as feasible, to our health-based goal of 0 for lead. Now that nuance is lost on many people, and many people misunderstand our action level for lead as a health-based threshold, and so that's one of the challenges we face.
Which is very similar to the approach that the Clean Water Act takes, which is a technology-based standard for cleanup, where the level is only set after you figure out that the technical feasibility is not able to be met. So that
Exactly like that, and it's similar in other cases to some of our other MCLs. So the next step of the process, pardon that diversion, is that we have to evaluate the feasibility of reducing the level of contaminant in drinking water, and that's with the use of best available technologies, technologies that have been demonstrated in the field, right? So bench level research is not really going to be adequate for us to rely on. We need to see that there are studies out there where water systems actually removed these contaminants, reproducible results to the lowest level. Measurement, the ability to actually measure the level of contaminant often is a determining factor there, because to some degree you can only demonstrate a treatment technology is capable of removing a contaminant to the lowest level you can actually measure that contaminant to. And what we need to be looking at is not just what a really talented analyst in a research level laboratory can achieve, but one that can be reproduced in laboratories across the country, because when we regulate drinking water, we have upwards of 150,000 water systems that are going to be sending water samples off for analysis. And so there's got to be laboratory capacity where those low levels can be achieved across the country. So that is a big determining factor in how we set our drinking water standards. The most conventional standard we set is referred to as an MCL. That's a maximum contaminant level that's measured at the entry point to the distribution system after the water is treated before it goes into the distribution systems. There's exceptions to that, like the lead and copper rule that we just talked about briefly. And then we also have to develop something called a HRCA, Health Risk Reduction Cost Analysis. And this is where we consider the costs that will be imposed upon the communities across the country as well as the benefits to their consumers. The costs largely are what does it cost to construct the treatment technologies, to install and build the treatment technologies, and to maintain those technologies, and the administrative costs with the states and the water systems and doing all the reporting they have to do, and then the benefits, which are largely measured as the avoided adverse health outcomes. So not only do we have to have toxicology that tells us what the lowest level is in that MCLG, but we have to actually be able to quantify the difference in disease incidence that will occur before and after an MCL comes into play, to be able to say this many fewer people will experience cancer, will experience neurodevelopmental impacts, and then assign a dollar value associated with that through various economic measures, such as the avoided cost of treatment, such as the lost income that children have if they have higher, they would have lower IQ than they would otherwise have if they were exposed to lead and other things. So we have to quantify those benefits, and then we have to, the administrator, another tough decision the administrator has to make is whether or not the benefits justify or do not justify the costs, I'm sorry, whether the benefits do or do not justify the costs at the closest feasible level to the maximum contaminant level goal, and if not, then is there another level at which health risk reduction benefits are maximized at a cost justified by the benefits. So it's a very elaborate and difficult process, which produces lengthy regulatory tomes, like the ones we issued just last week for the lead and copper rule, weighing in about 800 pages just for the overall description, and that doesn't count the tens of thousands of pages of underlying scientific analysis that are in the docket for that rule, which may or may not be assailed by litigants in the near future, and will be used to justify if we are sued on that particular regulation in the near future. And so with that, Chuck, why don't we turn back?
Sure. So let's, appreciate that, Eric. And so we'll move, I think, now to Courtney. Courtney Woods is Associate Professor at the Gilling School of Public Health here at UNC. And she's done a lot of work on underserved communities and households and the technical assistance needed there. So Courtney, what are the challenges communities and households are facing with access to resources to identify solutions to emerging contaminants? So I'll flip that. Oops. Did that, is that you?
Yes, but
Okay.
this
Okay.
slide doesn't address the question you asked. It addresses the second one, which is
Okay.
fine. So first, I want to thank you for the invitation to be on the panel. And yeah, I will share that I think my perspective is maybe a little different from a lot of the folks who have spoken already. I am an engineer and toxicologist by training, but I've spent over the last decade working very closely with communities, mostly in North Carolina and the Southeast, but also have spent some time doing work in Brazil. So some of the perspective that I'm going to offer here is based on what I'm hearing directly from residents. And so a lot of these ideas aren't necessarily my thoughts on what's best for communities, but it's mostly what I hear from impacted communities. So one thing to note is that, and thankfully Secretary Regan also mentioned this, is that not all private well users, and that's the population that I primarily work with, that not all private well users want to be connected to public water. There are very many residents who have a sense of pride in being able to access their water on their lands, and they want to find ways to have their water protected. So that's one thing to note. Many of them describe their water as being fresh, the best water they've ever tasted. And so I think that's an important perspective to bring to this session, that the end-all goal should not be to connect everyone to public systems, but that we need to find some strategies to protect those folks who do still want to be on private wells. That said, I do speak to a lot of residents, private well users, who don't trust their water, and that's the sentiment that we hear a lot, that they don't have confidence, they don't trust their water, whether it's odors, sulfur odors, or discoloration, or low pressure that prevents them from using their water for various reasons. And so rebuilding that trust is also, I think, another important part of our work as researchers, as health department officials, as other government agents. I think some of the challenges that I hear and see most among private well users is cost, cost of well treatment, of well maintenance, of testing. There have certainly, there's been research from UNC that's shown that communities of color, low-income communities are the least likely to test their wells. They're the least likely to install any sort of treatment. So that's a significant concern. There's also knowledge gaps, and I will say that I partially agree with your comment, Michael, on education, that education doesn't change behavior. I think there do need to be significant education campaigns as well as training campaigns so that residents understand how they can maintain their wells, how frequently they should be testing, and what resources are available for that. Another, I think, challenge is not just the mistrust that residents have for their water, but also mistrust in local and state officials. So I have heard residents say, you know, why should I trust sending my sample off, my water sample off to a state or local lab when, you know, that state agency is the same agency that is permitting polluting industries to operate in my county, and those industries have, you know, contributed to water contamination in my county. So rebuilding trust, engaging with communities so that they are a part of decision-making processes, and that we're not making decisions for them as technical experts, but that we're also incorporating their lived experiences into the decisions that are being made, and that we're performing community-driven actions. And then the last challenge that I think is certainly real in North Carolina and likely many other parts of the country is thinking about the most marginalized. So I often think about centering the margins. We know that rural populations, private well users are at the margins, but even within that population, there are second language English speakers who, you know, as providing an educational campaign in English is still not going to reach them, or training in English is still not going to reach them. So making sure that the information and resources that we're providing are able to reach those who are most vulnerable. That includes language accessibility. Also, I work with several community leaders who have visual impairments, and so just posting stuff up on the web and not thinking about digital accessibility is also a challenge. So thinking about the margins within underserved and marginalized communities is also important.
Are there policies that would help scale that access that the most vulnerable can move forward? What do you think about that?
Yeah, I mean, so what I've seen, I'll say in terms of federal funding that's coming down to the state level and how that's being distributed, I have seen there being this sort of prioritization in terms of who can access those funds. I think that's really important, making sure that that there's some sort of demographics requirements, whether it's, you know, median income of the population that would be served, or racial demographics of the population. So I think there are ways that funding, legislation that controls funding could ensure that we're reaching communities that are at most need. And those, in many cases, those counties that would be applying for that funding are also at low capacity. There's research that also shows in North Carolina, a significant disparity across health departments and their capacity to pursue funding and resolve issues that private well users experience. So I think, yeah, just building in sort of priority mechanisms and so that we're ensuring that those most marginalized are prioritized for how we're allocating funding.
No, I appreciate that. And since Michael is kind of taking notes on what we might put into some sort of output, the community disaster resilience zones, which were passed at the end of 2022 by FEMA to identify the most at-risk, most vulnerable communities to accept FEMA funding, but also designed to help direct other agencies toward those communities. And so the initial designations have been made, and so that's one way to do what you're talking about. So I want to turn to you, Vince. Vince Hill, Waterborne Disease Prevention Branch Chief at the U.S. Centers for Disease Control and Prevention. So what are the next set of emerging challenges, and where are the highest risks?
Great. Yeah, thanks.
Should we go to, is there a slide?
Well, yeah, I can do that as a kind of a point of context for it, leading right into the challenges. I think I've got it maybe next. Yeah, that's really blurry, but I hope you all get the point here. Is it's actually an image from a newspaper in 1910 about typhoid, and if we think in the, we've been talking about, hey, this is the last mile, et cetera. Well, if that's the case, for at least the United States and other countries, developed countries, it's been a marathon in a way. I mean, where we started in the late 1800s, early 1900s was, typhoid. 100 cases per 100,000 at that kind of level. And then, of course, with the advent of modern, 1908, with chlorination of water and advent of waste management systems, within, I think, about 45 years, that went about 100-fold lower. And so, dramatic improvement in protecting people from waterborne diseases related to water treatment and waste management, which CDC and other agencies have recognized as, one of the greatest public health achievements, ever of the 20th century. So that's where we kind of started from, and we've gone from that where drinking water was the main, issue, to now that we have very safe, we've got great, there are issues, but great infrastructure, regulations, practices around water system. I mean, the U.S. has, and other countries similar have some of the safest water in the world. And so, while there are issues, we use, because of that water, that level of water safety and confidence that hopefully people can have in the water that shows up to their households, we use water in all sorts of ways. And so, just a smattering thing. So, of course, we recreate in it with all sorts of different ways that we recreate. We use it for personal health care, nasal rinsing, CPAPs and things like that in the home. For bathing, we use it for industrial processes, for heating and cooling, et cetera. And it's all because we have, regulations and safe delivery of water that we're able to use it in all these different ways. And so what that leads to then, of course, is that a change in really the kind of dramatic kind of exposures that lead to waterborne diseases. And so I like to use this one as a way of just showing all the different types of exposures and ways that we can have infectious diseases. So this is focused on infectious diseases. From neurologic diseases to, water going up your nose and you get Naegleria fowleri infections. You get eye infections if you rinse your contact lens in tap water. Tap water is not sterile, right? So you get these infections. Respiratory infections, of course, Legionella is a leading one that folks know about. Of course, there's AGI and all the various enteric diseases, but wound infections, these kinds of, we're recognizing now that it's not just about enterics, and that biofilm pathogens and other contaminants in our water can cause these health effects in all different kinds of ways. And that makes it really complicated for people to understand, and also for health departments and others to kind of understand and be able to detect and recognize the issues and respond to those issues. So Heather did a great job. This is almost redundant if you were here in the previous session to talking about some of the waterborne disease work here. And I think I mentioned the top one there, and that is all water exposures. And really to kind of highlight this emerging paradigm shift for us around, yeah, it's not just about enteric pathogens anymore. I mean, it's about biofilm pathogens, environmental pathogens that are out there, and it's really different how do you think about them and control them because they live there. And it's about controlling their presence and trying to reduce that and also protect people from the pathogens that can be there. And so you can see the major drivers now. The way this works, on the left-hand side with the 7.2 million cases, this is an annual estimate based on 2014 data. That includes, enterics, biofilm pathogens, also environmental associated conditions like otitis externa, like swimmer's ear. It's all exposures. But you can see as you go to the right there that the biofilm pathogens are the drivers of burden of disease from severe outcomes, hospitalizations, deaths, and of course the direct healthcare costs associated with that. If we drill down, and we had a second paper that looked at the different exposure routes, if you look at drinking water specifically, you get the same message is that you still have millions of cases, and they tend to be driven by enterics in that case with drinking water. But then if you look at the more severe health outcomes, then you start seeing the biofilm pathogens start being the drivers of illness, hospitalizations, deaths, and the costs associated with them. So it's a major shift for us in thinking about how to control that and protect people from waterborne disease in the United States. And the last slide I'll have is, and so with that complexity, it also creates complexities for our health department partners, right? Because it starts with them. Civics 101, CDC, we other than maybe quarantine and public health emergencies, we don't have legal authority to go swooping in anywhere and say, hey, you need to do this, that, or the other around public health. The primary agencies are state and local public health agencies. And so we rely on them to collect the data, talk to people, and investigate outbreaks or other investigations, and then report that. Or if we can help, we hear about it, and then we try to help them. Otherwise, we do have some systems set up where that data can be sent to us. And I put a smattering here related to water. The major one that folks probably know about is National Outbreak Reporting System, which tracks foodborne, person-to-person, waterborne, and environmental outbreaks. And so my program at CDC is tasked with the waterborne part of the disease detection outbreak system there. Also, CDC gets data from the Nationally Notifiable Diseases Surveillance System and water-specific pathogens that are nationally notifiable. I've noted here. So you can see we're there, and you can see it's not all of the ones you can think about. You don't see norovirus there, for one thing, and you also, only Legionella is indicated there. And so if you're worried about, and I think the big drivers, especially for drinking water, we've seen non-tuberculous mycobacteria, Pseudomonas. Some of these can be really serious infections, really hard to treat, really devastating, and we really just don't have the data. Some states do surveillance at a state basis for some of these diseases when they have the capacity to do it, but it's not organized at a national level. It's not nationally notifiable for some of them. So I wanted to give you a sense of that. We do have other programs that are maybe pathogen specific that do some surveillance. Cleci virus, not norovirus is there, and they help the states kind of identify outbreaks and do surveillance that way. We do some for cryptosporidium through CryptoNet. Harmful algal blooms, we have a system for that as well. And so we do have some, but in this kind of net of surveillance, there are gaps, and it's a people-driven process. And so I think your question was challenges, and I think the challenge here is to, with all these kind of emerging issues, and I'm thinking infectious diseases, but of course we've heard about a lot of other ones. I think the, from chemicals and other exposures, the challenges is trying to ensure that the states and local health departments, which are really at the front lines, kind of have the support that they need, the resources they need, the capacities that they need to be able to detect these issues and serve their communities, be able to respond if they can, and then report that so that we can help track that from a national perspective and look at issues, contributing factors, things like that we can add value to. But But that essential issue is really hard because, like I said, it's a people-driven process. There are people at the end of that phone or making calls or doing investigations. And as time goes on, that becomes more challenging, especially when we have emerging issues like biofilm pathogens and some of these other complex issues. It's hard to keep up with it all. And so I think I see that as one of our roles at CDC, is to help provide that, the evidence base, the information that we can and the tools that we can to help our partners be better prepared to serve their communities.
Well, thanks so much, Vince. Appreciate that. So we have about a little bit less than 10 minutes left. So want to open it up to the floor for questions or comments. Don't be. I mean, I have a few questions to throw back at them, but if you have questions or comments, please do chime in.
This is a question for Chuck and Eric. So I appreciate the efforts that go into setting national drinking water standards and the impacts that are required for national drinking water standards. But there are many instances where a source of a chemical pollutant is maybe more local, and maybe it doesn't have necessarily a national impact, but it could have a very strong local impact. In a state like North Carolina, we have an amendment that basically prevents the state DEQ to set standards that are stricter than the national standards. So what is your response to how should we manage, or how can the state regulators manage these sources of pollution that are having a strong impact? And the example that I might mention here is 1,4-dioxane, where levels of 1,4-dioxane in the Haw River were 100 micrograms per liter. And the sources of pollution are fighting any regulation on this. So, and maybe there's no need to regulate 1,4-dioxane at the national level, but how do we deal with things like that? And there are many of these one-offs.
Well, I mean, I don't know what your answer would be, but different states have different requirements. So the Safe Drinking Water Act and the Clean Water Act can be implemented by the states. And most of the time, it's they're free to go higher than the national standard. The national standard is the floor. North Carolina has a different approach, and so there are other states that do that, but some states, the national standard is the floor. Is that, am I correct on that?
Yeah, and I'll build on that, Chuck,
sure.
so thank you. So Detlef, really appreciate the question. So the way you framed this, let me first acknowledge sometimes there are situations where there is state-specific contamination, and the Safe Drinking Water Act is largely set up to address national level contamination concerns, because of course we would impose requirements on all systems across the country, and that may be deemed as inappropriate for what might be localized. And there are states that have no more stringent than the federal standards. And so I will add to what Chuck has just said, which is to say that when we promulgate a standard, of course, states can be no less stringent. So we do set the regulatory floor, as Chuck has said. There are states, California and New York are notable states that have gotten out there and regulated contaminants before the agency has done that. But then there are other states that will only do so when the regulations have been come out from the agency. I will say, Detlef, since you used the 1,4-dioxane example, and Chuck's alluded to this in his reference to the Clean Water Act, there are a number of different statutes that come into play when it comes to particularly the anthropogenic contaminants, right? So in addition to mentioning the Clean Water Act, which could be brought to bear in terms of limiting discharges, there is TSCA, the Toxic Substance Control Act, which sets standards for toxic chemicals. 1,4-dioxane is one of those existing chemicals that the agency is examining. So that's another authority that could be brought to bear here to prevent the release of 1,4-dioxane or other anthropogenic contaminants, so that those downstream water systems, those community water systems, don't then have the burden of trying to remove that should we ever promulgate a regulation.
And I think one other point just to make is that one thing that, that I've talked to Sharon a lot about, and we've mentioned, is that water reuse can at the industrial level can be a solution to some of these to address any leakage issues that are out there. If there's a way to help companies along to implement water reuse systems, I think that's one approach to address some of the challenges that we're faced with, leakage into the environment. Other comments by the rest of the panel? Next question.
Thanks very much for being here. In the last part of the session, we heard that even when there is access to drinking water supplies, sometimes there's still preference for use of bottled water. We also heard that bottled water is not necessarily always the safest option for drinking water. And then in some of the populations that I've worked with, there is an affordability concern because alternative treatment methods like home filtration are not always affordable at the time that purchase is required. However, supplementary nutrition assistance will allow purchase of bottled water. So I'm wondering, going back to the question that you had posted at the beginning about providing safe and affordable and accessible options for risk mitigation, are you aware of conversations for how to bring in adding water filtration, point of use devices to SNAP or similar programs? And if not, who do we talk to about introducing that idea?
Well, I think there's, and there might be others in the room that are more knowledgeable about this, but there is a proposal out there to provide grants to households to access home filtration and other things. It's called the Healthy H2O, right? I mean, is that what? So, and that's it's part of the. Is it part of the Senate bill or the House Farm Bill?
It's basically both. Just part of the farm.
It's part of the Farm Bill. So it'd be implemented by USDA in rural areas. So that's it's a great observation. I think looking for those solutions. We have time for one more question.
This is for you, Eric. Coming back around. So I'm wondering what it would take for there to be a maximum contaminant level set for lead, for a few reasons. One, messaging-wise, it's really challenging for people in the United States to understand the difference between what's done with the lead and copper rule, with treatment-based action, versus there being maximum contaminant levels set for other contaminants, including arsenic, right, that's typically found in groundwater. And two, because the treatment-based level is set above where we can now detect lead and often find lead at the tap in childcare centers and schools. And we actually found in an analysis of about 25,000 samples in North Carolina that a statistically significant predictor of high lead was actually well water used that was compliant even under the lead and copper rule. And so things such as only testing one tap and being compliant with that don't correspond to actual water consumption habits that we're finding in facilities such as schools and centers. And so in our efforts to kind of better protect children's health, the EPA 3T standards seem to do a better job at that. So wanting to see what your thoughts are on that.
So thanks for the last part, which I think was a compliment towards EPA.
Yes, it was.
So allow me to recommend a recent publication that you may be aware of. It's called Lead and Copper Rule Improvements. It came out last week, and in which a significant portion of that document is dedicated to our discussion. So the requirement of the Safe Drinking Water Act is that we have to set an MCL as close as feasible, unless it's technologically or economically not feasible to ascertain the level of the contaminant. So we go back through a lot of the science about lead levels in drinking water in taps and the fact that it's highly variable. As I was stating earlier, it's going to, depending on how long that water has sat in contact with the lead plumbing components within the home, how much the water has been used within that household, what the fluctuation is in the water chemistry has been over a period of time. Lead levels are not going to be consistent from time to time. For us to set an MCL, it has to be technologically and economically feasible to say this is the lowest level that can be achieved by water systems. Because it's so variable, the nature of any MCL we would set would have to account for that variability. And so it might be a much higher level than what we might set. And then there's also the issue of the fact that the place that you have to collect that sample is outside of the control of the public water supply system. It's in the home. And so we only have the authority over the public water supply systems to the degree to which they have control, which we have more recently defined. They have control as long as they can have access, which is how we have imposed a requirement that they need to replace the full service line up into the home. But we have never, and I can't imagine the feedback, the blowback we would get if we would say that the water system has control all the way into a household plumbing and right up to their tap. So there are a variety of mostly legal complexities, but technical issues that come into play that prohibit us from setting an MCL. What would have to change is your question to me. So if we get to that point that I think you visualized earlier, that there is truly lead-free plumbing in every household, in every building in the United States, well then that variability, that temporal variability, that spatial variability in terms of how much lead levels are going to change over time may drastically diminish. But as the administrator said this morning, there are over 9 million households in the U.S. that are connected just with a pipe that is purely lead, but then that does not count the tens of millions of houses that have leaded solder, leaded brass, all that housing built really frankly pre-2014. So there's a big inventory of plumbing out there that's going to create that high variability that makes it economically and technologically infeasible to ascertain the level of lead.
Well, thanks so much. Please join me in thanking our panelists. And we have one more speaker to close us out. Don't leave yet.
Yeah, thank you very much. Just wanted to give a few remarks, about, this presentation this morning, even all the way back to Administrator Regan. These are complex issues that we're dealing with. One of the things that I think has come, time and time again in both panels, and then even from Administrator Regan, is the need for collaboration at all levels of government. This is not just a federal issue; it's a state issue. It gets down to the public health departments. There's many agencies involved here, so this is a collaborative effort. There's no one solution. Administrator Regan, spoke to this a little bit earlier about the funding. There is a historic level of funding that has come to EPA that is going out right now. It's actually insufficient to address the problems that we have. It's great that they have that. They're doing the best they can with it. The SRF is available. And there's other funding sources. I really was encouraged to hear about the call out to USDA Rural Development this morning and using those funds. But in addition to that, there is HUD CDBG grant funds that are available to communities. There's USDA NRCS funds that are available that could help with some of the source water issues. There's Bureau of Reclamation, which could be very important in underserved communities, especially with the tribes. That is through the Department of the Interior. So these are all over government in ways that we can work. Private wells is something that's near and dear to my heart. My master's thesis back in 2018 was around risk communication of PFAS contamination of private wells. So that is a huge issue. Dr. Woods, I was really appreciative of those comments that you made about why people are on these wells. Without the federal, without any federal regulations on these wells, it's very difficult to get at and encourage people to test their wells. Make sure people have the funding to test their wells, and to make sure that if you test your well and you find a contaminant, what do you do to protect yourself and protect your family? These are key issues. So it's not even just getting people to test. You have to make sure that they know. This risk communication, something that's come up quite a bit, is whether or not public health is communicating in the right way, whether or not we've taken some hits in public health on our risk communication, especially in the post-COVID-19. What does that impact? Are we doing that well? We need to be, working amongst ourselves to communicate that. So why do we need to get this policy right? And again, I'm going to go back to Administrator Regan. It's because of the young people. You know, we are dealing with right now, as you've heard just a few moments ago, we're dealing with decisions that were made not just prior to 2014, but sometimes decades ago, before most of us were even born, in what went into community water systems, you know, what materials were used, the homes, how they were built, our plumbing systems. My house was built in the 1950s. So these were decisions that are made. Now I have to deal with that to make sure that my daughter, who's 12, has, you know, good drinking water. So these are decisions that we've made. So we need to be doing that for the young people. So this is just something that is going to take at all levels, all of us working together. Healthy H2O Act came up earlier. It would create a grant program, a funding mechanism at USDA Rural Development. That is something that NSF supports. It's something that IAPMO supports. We work together collaboratively on these issues, and that's what it's going to take going forward. It's not just one bill. It's not just one policy, but it's all of us. It's taking the findings that we come from symposia like this, from conferences like this, and developing out policies that move the needle, that protect public health, and it's working together. It's not going to just be one entity that can do that. It's going to take all of us. So thank you very much. Really appreciate it.
Thanks so much, Vince. I appreciate it.